So the question is about doing something that costs very little, that is relatively safe, that could be given to the masses for an intervention that could reduce the burden of the most common disease in the country. So I like all of the premises, except that the comparison with water fluorination and tooth decay is a little bit of a stretch, because actually with fluorination of water you protect a lot. With right dental hygiene and fluorination, you basically do an enormous effect on tooth decay. By adding a statin to the average lifestyle of a high-risk patient older than 40 or 50, you are not going to decimate the epidemic. So it's got that, or a poly pill that includes many ingredients, not very expensive, mostly generic, and they're very efficient, is an element of a societal approach to risk. But I don't think that removes, I don't think it's equivalent to water fluorination. The equivalent to water fluorination actually is finding a way to convince people to do the right thing with diet, exercise, exposure to risk factors like smoking, and body weight management. That is one thing that nobody wants to touch, because if you say body weight, a patient says, "Are you calling me fat?" Right? And doctors don't even go there, and we don't address the issue of chronic overweight or chronic obesity, which is a big component of the risk presentation in our society. If you don't like that I say fat, you can cut it. Yeah.
Okay.
Yeah, so that is a good question. You probably have to edit here, because I was thinking of different kind of answers. It's a multiple step. Can you read it again?
Yeah.
I'll tell you when to stop. I think I forgot the beginning.
Okay.
Yeah.
So shall we take a contrarian view and consider...
Okay, yeah, that's what I was thinking. So it's fine, right? We can take it from any point. That is an excellent point, because atherosclerosis, the building of plaques, is so common. If you were able to look non-invasively and non-expensively at people who are 60, 65, 70, you would say, this is not a disease, this is something that everybody has. It's very common to have it, but not everybody dies of it. So for example, if you did autopsies in people who die at 95, and I would say it's a pretty good age to die, right? It's old enough for everybody who would say, I'll sign if you promise me that I live until 95. If you look at their coronary arteries, they're not. These people did not live until 95 because their coronaries are clean. They lived until 95 despite having atherosclerosis in the coronary. So according to your question, we have two types of disease at the very least. One disease that's simply there in the background and doesn't bother you, and another one that will kill you or give you a massive heart attack and make you disabled. So we need to identify, in addition to identifying presence of a plaque, we need to identify the plaque that kills. And so that's the concept of vulnerable plaque. The last part of your question is, why don't we step it up even more by saying, I want to know who are the vulnerable patients. Of course, vulnerable patients are patients carrying vulnerable plaques. So whoever carries a vulnerable plaque is a vulnerable patient. But according to your question, you're saying one approach is to really find the vulnerable plaque. Another approach is to identify the patient type that is likely to harbor the vulnerable plaque. And I think both approaches are valid today. We are closer to moving to the vulnerable patient than to the vulnerable plaque, because our imaging methodology just tells us presence of a plaque, whereas we know, for example, inflammation is a contributor to the paradigm that makes in a patient the likelihood that that patient is vulnerable.